Good afternoon and a very warm welcome to our conference delegates, in person and online to this session, System Linkages for Vulnerable Populations. Thank you to conference partner Homes Victoria for supporting the National Housing Conference. My name is Dr. Gina Zappia and I am the Research Program Manager at AHURI, and I am delighted to be facilitating this session. I would like to acknowledge the Wurundjeri people who are the traditional custodians of this land. I would also like to pay my respect to the elders, both past and present, of the Kulin Nation, and extend that respect to other Indigenous Australians present. Today's session is being streamed, and I'd like to welcome again those delegates watching from around Australia and some from overseas. This session is being recorded and will be available in the coming days to all delegates throughout the conference, or through, rather, the conference portal. A reminder that you can also ask questions at any time during the session, so just use your app for those that are here in the room or through the online portal for those watching online. We won't be taking verbal questions today. So if you haven't downloaded the app, which I'm sure you already have, you'll notice in your pocket program there is a QR code. This session will draw upon current research and industry expertise to examine how to improve housing, services and support partnerships. The session will highlight how system capacity and system linkages can be enhanced to ensure successful and sustainable tenancies for vulnerable households. The session will focus on the importance of service coordination to effectively address the growing complexity of needs and service delivery systems. And on that note, I would like to introduce our presenters. We have Associate Professor Cameron Duff from the Centre for People, Organisation and Work in the College of Business and Law at RMIT University. We have Stephen Hawkins, Service Integration Facilitator at Q Shelter. Karen Lococo, who's the Operations Manager of Engagement Hubs and Individual Plan Support at Sacred Heart Mission. And Spike Chiappalone, cohealth worker. To read more about today's presenters, head to the speakers section of the session in the app or online. And just to cover the format of today's session, we'll hear a presentation from Cameron, followed by a presentation from Stephen, and both Spike and Karen will offer a response to those presentations, and then we'll all join together on the stage to take a Q&A session from the audience. On that note, I'd like to welcome Cameron to the stage.
Thanks very much, Gina, and thanks to AHURI for all the hard work organising the conference. It's lovely to be back in the room. It's lovely to be speaking from Wurundjeri country. I pay my respects to elders past, present and emerging in the Eastern Kulin Nations. Of course, I'll start by acknowledging co-authors on this piece of work, Nicholas Hill at RMIT and Carly Valentine up at the University of New South Wales. There are a number of other people involved. I will leave it for the moment. The thing to say, this is a rather complicated report with lots of different elements to it, lots of interviews, linked data that I won't be speaking to today. The full report is available. It's been available for a little while. I've got the link there if people are interested. That should be reasonably easy to find on AHURI's website. So I'm going to rush over some of the material today because the report is rather complicated, and as I said, it's available for everyone with interest. What I want to talk about is the organisation of social care. Now, for a long time, and those of you who have worked in the sector know that this has been a long-standing problem. We recognise that people with complex needs, vulnerable people with complex needs, we need to find ways of coordinating service delivery in ways that address those complex needs more directly. We haven't done a very good job at this. We don't do a very good job at it currently. We've known about it for a long time, and so the challenge is always, what are the key barriers? Why aren't we getting better at coordination? Why is it so difficult to coordinate services? In some respects, COVID has made this very plain for us. So how to improve the coordination of specialist housing support, particularly within residential alcohol and other drug treatment services and inpatient mental health care. Again, I'll start with the things that we know very well. We know that leaving residential treatment is a key period of housing risk. Again, depending on the types of conditions that people are presented to treatment with, the sorts of circumstances they find themselves in, experiences of trauma, disadvantage and so forth. We know that leaving treatment is a key risk period, particularly for vulnerable individuals, we've known this for a long time in terms of the cycling through services. We know the social costs associated with this. We know, of course, the cost to individuals. We know that the costs in terms of our sector. Okay, I'm going to skip over the methods in the interest of time. I want to start with this quote because I think it really illustrates the scale of the challenge. I apologise for this being a rather lengthy quote. I'm going to read this, but we'll talk about the details as we go. The thing we all need to remember is that our homelessness service system, with only a few limited exceptions, is only funded for a defined period of support. We heard this morning about residualisation in our service sector. We talked about the rationing of care over the last couple of days. This is it in a nutshell, I think. Really, it's mainly only short-term support intended to resolve a temporary crisis in someone's life. So this idea that we can overcome, in some cases, decades of disadvantage that starts in early childhood, goes all the way through school and then inexperience of work people might have had, the idea that you can somehow manage or make up for these sorts of things through a 6-week intervention or a period of crisis accommodation is just farcical. This is the problem. We have a service system that is designed to solve particular kinds of problems. Now, I think it's fair to say, and this is with due respect to people who work so hard every day in the room, I think in lots of respects the service, when we're addressing these sorts of short-term problems, it works reasonably well. People who present to services, present to emergency departments, for example, present to, are admitted for a short-term psychiatric inpatient stay, in lots of cases, people receive the care and support that they need, they find the resolution that they might need to the particular problem they're presented with, and they move back into relatively stable housing circumstances, and we have no further contact with them. So a big part of this project involved looking at linked administrative data provided by the Department of Health and Human Services. And in something like 65 to 75% of cases, we know that people move through care, they receive the support they need, and their housing is stabilised and they move on, if you like. So in some respects, we've got a system that works reasonably well. What it doesn't do a very good job of, as we know, is handling much more complex cases where people are much more vulnerable, where the circumstances are such that people are going to need ongoing care for longer periods of time. That's not, at least in Victoria and New South Wales where we conducted this research, that's not really the service system that we have. So perhaps we shouldn't be surprised that it doesn't work very well. So is coordination of itself any solution to that kind of problem? Look, it's going to be somewhat important. I think there's no question that we have still relatively siloed service systems in this country. We still have, despite decades of interest in comorbidities, for example, in dual diagnosis, we still have a fair degree of separation between our mental health treatment system and our alcohol and other drug sector and our housing sector. So obviously there are instances of good practice that we can draw from in understanding how these services can work together more effectively. But I think it is fair to say that we have a legacy of service separation, of differentiation in the delivery of care that we're still trying to overcome. I think that service coordination, more effective models of coordination, I think this is part of the solution, clearly. But I'm not quite sure that it's ever going to address the kind of housing shortage gaps that we confront in our system. So what as a research team, what we tried to understand was what is the nature of social care? How is it delivered effectively? What does it entail? What does it achieve? So sometimes, in speaking with service users and speaking with service providers, care is a fundamental part of the work that people do every day. So in some respects, we think about care as a particular kind of work, a set of practices that people are paid to deliver. And certainly we spoke with service providers who talked about the challenges of providing care, and they talked about it as a kind of work. So that's important, of course. But what we also found is that effective care that leads to significant improvements in someone's life, this is a very different type of work, very, very challenging kind of work, and it involves a high degree of very, very refined skills that take a long time to develop and need significant organisational support. So one of the things that I didn't realise we were going to end up spending so much time talking about as a group was really a whole host of workforce development, training and support needs, looking at the work of social care, looking at how we support a strong, viable workforce. So what we found is that the work of delivering care in an incredibly fragmented, complex service landscape is very, very challenging. So another long quote, I apologise for this. I wanted to emphasise, though, that we found a huge number of instances of really effective support, and I wanted to highlight in this quote what that might look like, because I think it's really important that we recognise that the service system can work, And when it does work, it can make a very significant difference. And so I think sometimes I get invited to speak at sessions like this, and I feel like, what we're talking about is how woefully inadequate the service system is, how broken it is, how ineffective it is, how it doesn't work. And clearly we've had a lot of discussion around that over the last couple of days. But I think it's also important to emphasise that we do have models of best practice. We do know what works. And when programs are funded to deliver that kind of care, we get good outcomes. So I'll jump in and out of this quote because it is very long and I don't want to bore you all with it, with me reading it. What I love about this quote is that it's this idea of tailored support that responds to the circumstances that people confront and what they really need in their lives. So in this woman's case, she's talking about her daughter. Now, the backstory here is that as you probably won't be surprised to hear, a very difficult relationship. She's estranged from her daughter. She's recently returned to living with her. This is a complicated relationship. And the relationship between mother and daughter is improving, but it's improving primarily because this woman is getting help with some everyday aspects of mothering her teenage daughter. So for me, a big part of it was all the paperwork. Like, my worker determined that it was time to put away the lengthy forms that we have to fill out and just start having conversations. After that, she started making referrals to a whole range of organisations to help us. She put all these things in place. This is the bit I love. She had youth workers come and take my daughter to the supermarket and buy all the things she needed, take her out and get credit for her phone, take her out and about. Whether it was looking at schools and taking her to school interviews, whether it was finding guitar lessons for her and giving her a Myki card, so that's the Melbourne public transport card, a Myki card so she could travel to lessons. All these things meant she could independently continue on doing those activities without my involvement. She was always thinking 2 steps ahead. Now, for those of you in the room who've worked in these sorts of roles, this starts to look like a sort of old-fashioned case management type of work. That you think about, I'm not thinking about what my role is in terms of its organisational classification, what I'm supposed to be delivering. I'm going to think about, what does this woman across the table, what does she need? How can I help? So I need to go and get a Myki card for her daughter so her daughter can get to guitar lessons. That's going to be helpful. That's care. That's not, what's my role, what's my job, what are my key performance indicators, or what am I supposed to be doing? That's, how do I respond to the need that's presented to me across the table? Now, I think in some respects we've lost track of that idea of that's care, that's caring for, thinking about how do I respond in an effective way to the need that's being presented to me. Always thinking 2 steps ahead. So, what this woman needed, the quote on the last page, what are the conditions of livable life? What's going to help me live a more meaningful life? What do I need? What kind of support do I need? So one of the challenges with the work that we found is that, our service systems still respond to particular kinds of mandates. So if you present at psychiatric inpatient care, the people that you confront, people who are paid in that organisation, are going to look at you as someone who needs mental health support. And they're going to, and obviously if you're presenting in a psychiatric inpatient ward, that's a good thing. But they're going to think about, how can I address your mental health needs? Oh, I hear that you've got, a difficult relationship with your daughter and that you're not sure if you can really return home. I'm really sorry to hear that, but I don't really manage housing, so I'm going to refer you to someone. I'll get the social worker to come down in a minute and have a talk to you about your housing. The social worker may or may not appear. The social worker may or may not know anything about housing. And this is the challenge of, how do we get service systems to talk to one another? We have to find a common language for thinking about, how do we deliver person-centred care, irrespective of the kind of mandate that an agency might have, whether it's housing or mental health or addiction treatment. How do we start talking about person-centred care? How do we start developing, implementing, more holistic models of care? These are very old ideas, but we still struggle as a sector, across sectors, to find what's the common language for talking about these things. So we pinched an idea from disability support in the United Kingdom around this notion of livable life. This is an idea that appears all over the place. We've taken inspiration from some work in disability in the UK. I really like it. Now, why I like it is that it's finally putting service users, care recipients, at the centre of discussions about what is it that people need, how can we provide care, how can we provide the support that people need. So this is what we mean by 5 minutes. Thank you. This is what we mean by livable life. This is on this again. I'm apologise. When you do qualitative research, you really want to leave as much of people's voices in them. But I realise that sometimes on a PowerPoint slide, They don't look quite as neat as I think they might have. I love this quote because I think it's an illustration of the sorts of things that we're trying to achieve with really good service provision. And it doesn't really talk about service at all. The last few months now with the dogs, I'm getting out more. I'm settling into the area. I'm talking more with the locals. Like the lady across the road, there's a little boy across the road that comes out and he's always looking for the dogs. Like when we do our afternoon walk, he'll come over and say hello. I've got the lady next door that comes in once a week with a plate of chocolate chip muffins. So we're starting to find our, like I said, it's not just a house, it's a home. And I'm finding that I feel, not only do I feel on my own personal journey, but like I'm not a strain on the system like I was. I feel like, not that I'm giving back, but I feel like I'm not in trouble with the law and stuff like that. I'm not a strain on taxpayers, if that makes sense. Like I'm living in my community more. There's a ton to unpack in this quote, right? You know, like just the ambivalence in this, right? You know, the extreme, you get this sense, and I remember doing the interview, just this sense of you know, guilt and remorse about this idea of, I know that I've taken up a lot of people's time. I know that I've done that, you know, and I know that I haven't always been an easy person to get along with, you know, but but what I really wanted, I want to talk to the lady next door, you know, the chocolate chip muffins, like something, you know, in a sense, trivial and mundane, this idea that this is what I need. I need help to kind of get back to this. So yes, I'm going to need psychiatric support from time to time. Yes, I'm going to need help with you know, substance use issues from time to time. You know, but you know, what is it that we're all together trying to achieve? We're trying to achieve this, that people feel that they're living a life of meaning and purpose, that they feel that they belong in their community, that they feel like they've got a place and they're making a contribution of some kind. All the things that we want for our lives. So how do we get there? Our service system is not set up with that kind of goal in mind. Our service system is set up, you know, mainly in order to provide short-term emergency support to get people back on their feet. That's the way we think of our system, like this idea of a hand up, you know, the idea of you're basically living a pretty good, stable, comfortable life. You've run into a bit of trouble. You need someone to kind of help pick you up, dust yourself off and get moving again. You know, as I said right at the outset, that's in lots of instances, that is what people need. And our service systems are quite effective at delivering that kind of support. What we don't do very well is help people when they've got much more vulnerable, complex needs, and we don't really have an understanding of how do we get people back to a life that's meaningful. So at best, the work of care coordination is the work of restoring livable life. With lots of agencies working together, we have lots and lots of models of how this can work. It's incredibly intensive work. It's difficult work. The people who do it struggle because it's so hard. We don't support them very well, we don't pay them enough, and we don't have good models for supervision, training, support, all these important things. We're going to hear a little bit more about that from other speakers on the panel, so I might leave that there for the moment. But I guess the one idea I want to leave you with is this notion that a livable life requires social infrastructures. We heard talk about that, you know, a critical social infrastructure. Housing, of course, is part of a critical social infrastructure. What if we actually started designing social care in an integrated way, so we started thinking about what are the infrastructures that people need to live that kind of life? We need housing, obviously, but we also need a whole host of social infrastructures. We need what we're calling here affective infrastructures. People need to feel connected to place. They need to feel connected to family. They need to feel connected to a social community, a social network, a sense that this is my community, this is where I belong. How do we provide infrastructural support to help people feel that way again? So I've said here we need a new organisational for integrating care work. That's a horribly academic way of saying it. What I mean by that is we need some way of thinking about how do our services work together. Social care works together by building, restoring, maintaining, repairing, replacing a set of infrastructures that people need to live well. So substance use treatment can address aspects of that. Housing services address aspects of that. Mental health services, family violence, the whole gamut of services that we work with. What we need is a way of thinking about how do each of these services contribute in their own ways? How can they work together to restoring, repairing these sorts of infrastructures? I've said here we need to unlock the black box of practice because I don't think we know enough about what people are actually doing in care. I understand that you know, we'll talk about that across the rest of the panel. I'll leave it there. I realise I've covered a lot of material reasonably quickly. Happy to answer questions afterwards. Good. We've got
so much, Cameron, and I'd like to welcome Stephen. have some tech support.
Thanks, Cameron. Great introduction. With hopefully the next 15 minutes will be somewhat complementary with regards to an initial conversation about some of the quandaries that Cameron's put on the table, aligned with some of the work that's going on currently in Queensland. Before I commence, it's great that the slides are up. That was a bit of a worry. I would also like to acknowledge the traditional custodians of the land where we're on, the Wurundjeri people. I'd also like to extend that to the Turrbal and Yagara people, where I come from in Brisbane, and I extend that also to all First Nations people here, online and across Australia. So, Cameron used the words care coordination quite a few times during his informative session. What I'm going to do is expand on that from a more systems and operational level. I concur with everything that Cameron says. And really, as the slide will allude to because of time, there's an understanding, and we all know, so there's no egg-sucking teaching going on here today, that usually when someone is experiencing some form of housing crisis, there are other life challenges, issues, and I call it the backpack of challenges. Yet, as Cameron said, the way the service system has been set up is in a very much, you'll do that, you'll do that, you'll do that. And the key question is, how do we do that together? Not just together, I know I'm working with Mr. Smith and so am I, but in a coordinated way. We talk about service gaps, we talk about service saturation, which alludes to the fact that care is not coordinated. We're also challenged by some service landscapes that might not necessarily have the resources required to respond to the need. But what have we done about that? What time have we invested in saying, okay, here's the service system, here's the landscape, but what's the need of that place? So today I'm going to touch on a really strong and effective methodology that we call place-based, because it is about the place. Homelessness can be different across probably Melbourne as it is in Brisbane, so we can guarantee that homelessness is different on the Gold Coast as it is in Cairns. But we all do the same thing. There's no uniqueness. We might all be in homeless outreach service, great, that's fine. But we're not doing things together that can respond to the needs of that place in a coordinated way. So in 2019, following some extensive consultation across Queensland and as part of an initiative called Partnering for Impact, the Queensland Government provided an 18-month commitment to allow the Service Integration Initiative to explore what Cameron and what I've just talked about over an 18-month period. To do that as well, as part of my role as backbone support, which we'll talk about in a minute, we developed an evaluation framework that could actually test the outcomes and impact of putting together a more coordinated way of working, which we call intentional care coordination. So as I mentioned, it's at the operational systems level. So we've moved away from those more goodwill type models where keen services come together and, you know, there's lots of, let's call it intensive case management, but then they all go back to their services and we've missed the coordination side. So as you can see here, informed by collective impact and functional zero approaches, the idea was to stand up a dedicated regional care coordination facilitator, And I can just point to a colleague in the audience today here, and Tracy, thank you for being here today. Tracy represents the Sunshine Coast. So it was a dedicated resource. We had an array of auspiced organisations. This was not a centrally run initiative. I'll come back to the term place-based. So by having somebody placed in each region who then can connect with the regional landscape, place-based strategies and responses can be started to be pulled together. So what was the intent of the initiative? Very similar to Cameron's intro. I'll put my glasses on so I can actually read it myself. Collaboration and integration of housing, homelessness, and the broader service system. I come back to the point. Somebody's not just going to come into your service if they even come into your service first. And I refer to the array of what we call primary contact points, that people are doing it tough, and we've seen that during COVID, people that are doing it tough for the first time in their life don't know where to go. They might walk into a local council office. They might be seen getting a shower in the swimming pool. They might just be in their car because they're, fight, flight, or freeze. So this was about bringing that whole service system together so that when someone attempts to access the service system, not just housing and homelessness, the service system, there's an array of established touch points across that region to ensure that they can then access that system and navigate it in a more streamlined and less trauma-invoking way. Another key piece of work that the coordinators have to do, as well as bringing the service system together, and again, Cameron alluded to it, was to develop regional structures or scaffolding to ensure that the service system had pillars, had communication pathways, had response mechanisms and escalation mechanisms with regards to what I alluded to before. Hold on a minute. Look at the last load of referrals, and I'll get onto the database in a minute. This is the need of the region, but look at our service landscape. But who do I tell? Is it a housing issue? Is it a mental health issue? Is it an AOD, or so on and so on and so on? So one of the key remits of the coordinators, I won't say their long name all the time, so it's coordinators, was to ensure that through the collection of meaningful and contemporary data, the place-based alliance is formed. The alliance responds to the need of that place. It's not just a clique coming together. We all like working together. It's all great. We'll have a good chinwag, see what we can do, but we'll toddle off. This is a strategically designed place-based alliance that's been put together to respond to the need of that place. So there's accountability. There's organisational commitment, not personal commitment. And the coordinator's role was to lift all that up to ensure that that alliance is in place and the structures around those alliances are in place to communicate the findings, the risks, the issues, and the opportunities. I think I better start moving on a bit. I've really covered that. That's the coordinator's role. Yes, Cameron, probably don't get paid enough. This is not frontline service delivery. This is the helicopter view that we need to have. There are so many moving parts in our service system that there needs to be at least someone that sat just above that, reviewing the landscape, to have that strategic and operational lens on, to recommend changes. If through the collection of data, our services are saying we're creaking, we're at capacity, or we have an empty chair because there's not a service that can fill it. My role as the backbone, and those that are familiar with collective impact approaches, is one of the 5 principles. So effectively, my role is to support the 10 regional care coordinators across the 9 regions that look after 12 intentional care coordination groups or place-based alliances. So effectively, the need of the region is down to me if they say, hey, Steve, we haven't got this, or we haven't got that, or what do you think about that? It is also about capability building, not just of the coordinator role, but capability building of the region to respond better to the need of that place. And some small other tiny little bits of work, like developing a whole service delivery framework and an action research framework, were also part of my remit to then deliver the final report that we have. So watch this space, it may be released in time. It was presented to government in July with regards to how we think it went. But more importantly, take the rose-coloured glasses off. It's only an 18-month journey to date. What we need to do to get even better. Now, in reading that draft report, the government then saw enough value, so we're in a really great position where we're now funded through to 2025 because of the initial outcomes that were gained just during the implementation phase. So, I talked about structures or scaffolding. I've done a very simplified, because we know each region has many, many mechanisms within it. This is pulling up the real key mechanisms within each region that are considered valuable to the functioning of a multidisciplinary care coordination team or the place-based alliance. Sorry for the acronyms, I'll run through them, but we all live in acronym land in this sector, so I'll be quick. Obviously at the top, that's our Department of Communities and Housing. So you'll have your own names in your own respective jurisdictions. There is a centralised governance group that sits over the whole initiative. In Queensland, we have housing networks. It's called a housing network, but the membership is across the broader service system. So I see it as a key communication platform that comes together monthly or every 2 months. In the middle is a care coordination facilitator, as you can see. There's a graph just to show what that might look like. In a minute, a chart, sorry. The CCG is the care coordination group, or the place-based alliance. And more latterly now, we've started to move into the PBLGs, which is place-based leadership groups. And SOG as well, we're having to start to form executive layer groups that can come together and either decide if it can be resolved at the regional level or through the governance group be pushed through to central. So as I mentioned earlier, we've got the participation wheel. 2 minutes, whoa. The participation wheel. That is now measured. We know exactly what services are involved in a given month. Not just those that have come round the table, but who've referred. Who are the lead agencies? Who are the support partners across care plans? And as you can see there's quite a number, and we've got around, in any given time, between 250 to 270 services involved in responding to the needs of those that are homeless, at risk of homeless, and meet the threshold of complexity or exceptional need. So this isn't, I want a house, here's a key. Care coordination at this level is about supporting those that services have had to refer because they just don't know how to take those forward. I touched on the CMS. In partnership with the government, we are developing a purpose-built shared database platform. That allows us to collect key indicators of inflow. Where do people come from? We need to know that, hence the functional zero approach. Where are they coming from? Are they rough sleepers? Are they at risk? Have they been recently evicted? Have they previously disengaged? Or are they exiting care settings? This is just some very quick data, and again, this is available for you to go away and digest. Complexity, that middle column. There's the complexities. Managing self, so those with intellectual or developmental issues, 30%, 1 in 3 households. You can see the households we've already assisted, 1,477. that includes 750 children. And ultimately, the top right-hand corner, despite complexity, we've got 2/3 into stable and sustainable housing. Now, we're being really hard on when we say that, because it's an easy term to say. So that's why you might think, oh, only 63%. We know it's not a yes-no answer to where people end up. As you can see, there's an element that unfortunately are incarcerated or go into longer-term healthcare settings. There's lots of different potential outcomes that what we might say, well, that's not a good outcome. It probably was better than where they were before. The red box, again, continuous improvement is through this whole initiative. Why are people disengaging when they're in the support system? We're starting to learn and collate the data that tells us why a household or an individual has disengaged with the care process. We need to inform practice. We need to inform government. 7% disengagement rate. Why? Services are too busy. There is no services. People can't wait. I'm going to go from the key takeaways more to the, just wrap up now, it's my last slide, you're probably pleased to hear. We really want to, we need to work on the role. The role is critical. It is a very, very integral role. We need to start to put together, and we're just about to start this journey, put together regional capability building and development plans. We need the whole region to develop its capabilities, not just the services within the place-based alliance. So we're actually going to start to put a framework together, each region, that feeds into a statewide development plan. We're going to look at this, the system. We're going to ask people what works well and what's still broken. How can we fix it? So some significant service design work is going to take place now in the next few years. And we're also then going to continue to develop the CMS and test it across services so that data is readily available, so that households, when they're traversing the system with multiple care providers, they don't need to keep telling their stories. That's me. Thanks for your time today.
Thank you so much, Stephen. I'd like to welcome Spike to the lectern to share his thoughts and experiences. And I didn't introduce you very elegantly before. A peer worker at cohealth.
Yes.
Welcome.
Okay. That was awesome. Yeah. You guys are awesome. I guess what I came here to share with you guys is what it's like to be a peer worker in the City of Melbourne, and what it's been like to be a peer worker in the City of Melbourne for the last 5 years. And one of the things that Cameron, you mentioned, one of the quotes you had was the individual saying, "I don't want to be a strain on the system." That's a massive, like, we spoke to people that have been in accommodation, in the hotel accommodation through COVID. Almost every person that we spoke to felt, when we asked them, why do you think you got the accommodation? They didn't feel that it was accommodation because they had a right to housing. They got the accommodation because middle class Australia wanted to save itself, basically. And there's a real feeling amongst the communities that we support, or the community that we support, that, there's a real stereotype about who homeless people are, or people who are struggling, who they are, their habits, their value system. I remember seeing stuff in the Herald Sun from 2017 where they were taking photos of someone kicking a bin over, or there were stories in the Herald Sun where they were claiming that people were using their pets to earn money. And there was an unaccredited story. So it feeds this impression amongst the community that they're not welcome. They don't deserve what they get. And so that's a real barrier for a peer worker or an outreach worker when they're doing their work. That's one of the first barriers we have, is that people don't think they deserve the support, or they find it difficult to ask. I mean, it's difficult to ask for support just generally in the world that we live in, but when there's a whole there's like a culture of bashing people that are vulnerable in difficult situations, which was happening for a long time. It makes it even more difficult because we struggle to ask for help just generally. People, we do. And I just want to use an example. For me, I was talking to Shina on the way in here. I was thinking, so what's a story that can sort of communicate? I guess what we're talking about is relationships. Like you guys, we want services to be more responsive to the needs of the people that they work with. We want them to be person-centred. We want them to be holistic. We want them to be non-judgmental. We want them to be respectful. So the culture of the people. So that's what I try and do in my everyday practice, is to practice those things. And so that's what we all need to be conscious of, is that when we speak to people, I'm not suggesting that there's people out there that are rude to homeless people, but just, it's about being really, careful, because people are people that have been through that sort of stuff, even a couple of weeks on the streets of Melbourne can be traumatic. Homelessness is a traumatic experience. And to ask, we've heard a lot about housing first and how important that is and how great that is, that's happening through the H2H thing, which it is, everyone, housing is definitely a human right, but it needs to be practiced. It can't just be a slogan, yeah? When someone's had a long-term experience on the street, they might be, for example, my situation was, I had a drug problem, I had hepatitis, I had a lot of things, I was home, there was a lot of stuff happening. So I really needed that the person I saw who was supporting me to see me, the human being, to see Spike and not this collection, not a collection of pathology, all these problems. So that's what I needed for them to see me as me. And so I was telling Shina, I have false teeth, yeah? So I lost my teeth because I was a doctor shopper in the past, yeah? So the doctors that I was seeing to get my drugs or whatever, occasionally I would see them for legitimate issues, like I had infections in my mouth. So because he made assumptions about who I was based on how I looked, he just assumed that I didn't care about myself. So rather than telling me because I disengaged from the general community, I guess, because you don't feel welcome. You don't feel welcome. And so the doctor, rather than saying the dental hospitals on Swanston Street, maybe you should go get some, because that's public, you could get some dental help, he just gave me antibiotics. So every time my mouth flared up, I went for the antibiotics, and eventually I lost all my teeth. So that's an example of I guess what I'm trying to communicate is he was never mean to me, he was never malicious, but he was irresponsible, and he wasn't fulfilling his role as a primary caregiver, I guess. His duty of care to me was not just to look after my immediate need, but so what do we do about this in the long term? So I guess what I'm saying is that people in vulnerable communities, the people that we see at cohealth every day, really struggle to ask for what they need. They've heard all that stuff about who they are and like it's, no one goes hungry in Melbourne because you can get a ham sandwich occasionally, or there's one or two drop-in services. It's that sort of attitude that filters through, and people lose hope. They feel like they're not valued, and it makes it really difficult to then try and build them up again, and to remind them that they do. So I'll just finish up by saying that, I think, just the holistic, person-centred, and these people, vulnerable folks are incredibly resilient. You hear that a lot, and that's because they have to be. So, so I guess, be kind. Cheers.
Thank you so much. Karen, you have the giant task.
Yeah,
No pressure.
I'm not quite sure how I'm going to follow that, Spike. That was amazing, actually, and really kind of hit me. And I took some notes during these presentations just to kind of talk about where we're at. One of the things that Cameron said, and you've been quoted a lot now, is that the service system can work. And as I work at Sacred Heart Mission, I was a J2SI Journey to Social Inclusion manager for a long time. Now I'm in an operations manager role. So I've seen kind of how long-term support can actually change people's lives. When I came here 8 years ago, J2SI was like this brand new thing, and we're going to work with people for long periods of time, and they're going to be housed. It's going to be great. And I was like, we've been doing that in the U.S. for a long time. Anyway, since then, I've been reflecting on what's happened over these 7 years that I've been in this sector in Australia. We started with J2SI with a phase, a second phase of a research study with 60 people we worked with. They had case managers, low caseloads, 1 to 6, so that we could really provide those wraparound services. We got some really good outcomes. People were housed. We were funded for 3 more rounds of J2SI. That's a social impact investment. It's a long term. It's not one of these short term kind of supports, the 6 to 8 weeks or whatever. We're able to work with people long enough to figure out who they are, where they want to be, and how can we get them there. And I think that's one of the biggest things. It has exposed to me a lot of the gaps that Cameron kind of spoke about. Everything is very siloed. You have mental health over here, you have AOD over here, you have homelessness over here, and then you have, the worker that's kind of the hub trying to bring it all together. But if you don't have the buy-in from the rest of the services, you're not going to get anywhere. That being said, I have seen so much progress, and I think I met with Cameron before we even heard of COVID-19, so it was a whole different thing. I've seen so much change, and it's not just through H2H, it's through kind of working together in various kind of consortia to address homelessness with Greenlight, and now homelessness to a home. And I really do believe the key to it all is the long-term work, that being able to advocate and work directly with the people that we're providing services to so that they get their needs met. And that they're able to, you've used a different term, but I always say live their best life. And the funny thing, or not, it's not funny, haha, is I found when I came here and I started talking about social inclusion to case managers, they were kind of like, well, I don't know how to do that. Ask somebody what they want to do. But we're talking about people who are kind of at the pointy end. They experience really long-term homelessness and chronic disadvantage. And if you said to them, what do you like to do? What do you want to do? Where do you see yourself? They're like, I don't know. I've been too busy trying to survive. Now that we've been able to house people relatively quickly within the first 6 months and stabilize them, we're seeing lots of change in that area, because housing is absolutely essential. Please don't get me wrong. But the other thing that's absolutely essential is that people make connection in their community, that they find what it means to them to live their best life. It's not for me to decide who's going to do what. You know, I am not God. I'm only standing up here trying to follow someone who evoked a lot in me. Anyway, you know, I think, and that's what really hit me with some of the case studies that Cameron gave, was those are the important bits. And I've heard that so many times in talking to people that we've worked with. It's not necessarily the fact that you're going to, the house is important, and providing the sustaining tenancies and working with the housing provider and getting people to medical appointments is important. But if they don't have something to look forward to at the end of the day, that's when it all falls apart. And it doesn't fall apart in the first 6 months that you might be providing support, which is, you know, it'll happen 18 months in, 12 months in, usually when support has dropped off. So some of these longer term support initiatives that we're doing, like Journey to Social Inclusion, H2H to a degree, Green Light supportive housing, it is the wave of the future. Housing first, yes. We talk about it a lot, but we need to really do it. There's a lot more that we can do. We've incorporated a lot of the Housing First principles in Australia. My time's up. But you know, there is a lot more work that can be done. And thank you for listening. And I'm sorry that I was a bit disorganized. I just was caught, with a bit of emotion. Thank you.
Thank you so much for all of our speakers. I'd like to welcome you all back to the stage, please, for our Q&A. For our delegates, can you please, we've got some fabulous questions coming through on the Q&A app from both our in-person and virtual delegates, but if you could pose more, that would be greatly appreciated. I might just start as our presenters are settling in. One of our delegates wanted to thank Spike for sharing your story. You are courageous and it's a great message. So that's a positive way to open up our Q&A. There's just I myself took furious amounts of notes, as you do when you're involved in these wonderful sessions. I'd just like to open, though, a question to you, Stephen, that came from our delegates. What's the funding model for holistic care, especially for those not eligible for NDIS?
In the context of the initiative?
Yes.
So the initiative is funded independently of current contracts, whether it be housing and homelessness, mental health. The funding really is to introduce a dedicated resource to ensure that those services work together in providing that person-centred, holistic care. I'm hearing myself. The West Country accent's coming through.
It's fabulous.
And look, you know, with regards to longer term, as Karen alluded to, you know, one of the key things that our coordinators are working on is ensuring that we are moving the regions to outcomes-focused ways of working rather than outputs. We know we're all constrained and the service system's got a long way to move, both at the practice level but also at the funding level with regards to integrative funding. And yet we all do fantastic work, quite possibly beyond the own remits of what services are funded to do, purely because they care. Something that Spike, you know, you really touched on there. They care. You're in the job, we're in the job because we care. And normally then, with that, is, let's call it overreach. And as we know in this sector, that can usually lead to other forms of things such as vicarious trauma and burnout. So by having an integrative, holistic approach, we're sharing the love, we're sharing the care, we're also sharing the workload to ensure that the household or the individual is getting the respectful support that they receive, and not just, I can only do this or I'll try and do that. So almost tokenistic and insulting, similar to what Spike was alluding to.
I'd like to keep the conversation open to the panel, and if I may, at different points I'll interject with questions. So if there's anyone on our panel that would like to respond or to contribute further.
I guess for I guess for the people that, like we see at cohealth, most, a big majority of them are rough sleepers, and you know things are so hard. You know, things are so hard for those guys, and you know they might go for weeks without anyone knowing their name, and it's the only attention they get is the police. Do you know? And I get that's where that holistic care comes into it. That's where the peer work, in terms of just sitting with someone and having a coffee. There doesn't have to be a goal at the end, but sitting with them and you learn who they are, and then you learn, and by visiting them or hanging out for a while, you learn. They tell you stuff about who they are. They're dying to tell you who they are. Most of these people have been like when I met my peer. It was like someone was being paid to hang out with. It was amazing. So yeah, I think it's just people. It's part of our human condition. Everyone wants to be. We want to be liked. We want to be respected, and we want, as you said, we want to feel connected to our community.
Can I respond back?
Absolutely.
So the idea of coordinated care, and as Spike alluded to there, we've all heard of speed of disclosure. We all know as well, we work with people, communities that have had negative experience of the service system before, are guarded. They may have some form of illness that stops them from sharing through fear of whatever they say, child safety, or coming from overseas. They might feel that they'll be responded to in a negative way. So coordination is to ensure that the speed of disclosure is taken into account with regards to those households, that proper rapport can be built so that a full picture of what that household really wants can be gained. We talk about housing first, and absolutely 100% behind it. It can't be housing only. True. It's got to have the tailored, and I say tailored, I'm not a fan of wraparound. It's got different connotations for me. Tailored support that can come in and go when the household requires it. Not because it fits a funding agreement, or I've got to see you 3 times a day, etc., etc., etc. It's about tailored response, but being around for when that household feels, yeah, I can share that now.
Can I talk? Can you, one of the things that I actually had meant to mention is just, that's another change that I've seen over the past 7 years, is that we're now, when I started here, there were not peer support workers in homelessness. And now, at Sacred Heart, we have 3. And I feel like there's such important positions. And then it's almost like every meeting I've been in about new services, I'm advocating, no, you got to put, because if you want to talk about service coordination, I mean, yeah, it's happening at, all different places. But if someone has to go to maybe a detox or a mental health treatment or even court, and, the case manager, sure, they can go with them, but is it the same experience as going with someone who's been there? No, it's definitely not. It's not someone who kind of has, you can have empathy, but it's not a shared experience. And yeah, it's just really, really important, and I meant to mention that, so thanks.
Stephen, I was really struck when you were talking about the place-based methodology, this collaboration and integration of housing, homelessness and broader service systems, and I typed this in bold font, less trauma-invoking way. Can we talk a little bit more about that?
Sorry, can you just expand on that?
A less trauma-invoking way. So this integration and collaboration provides that service user, that human being, with support if they've had interactions with a service system that's been disrespectful, it's been trauma-invoking. You're aiming to, through your collaborative and integrative approach, to provide a less trauma-invoking way for them to access these services.
Yeah. So it's about being around. It's not, I'll be there at 9 o'clock on a Monday. It's not there, I'm driving in, driving out. Or in some cases in Queensland, and probably the same in some other states, fly in, fly out, for our remote communities. It's about being around, it's about creating the environment where people feel comfortable, have permission and protection to speak. And you've just got to be in there for that. You've almost got to be wearing their shoes to a point. And That's a great, bit of a segue for peer. And another colleague I know is online, Naomi, she worked with me in a previous life, where we called it the third dimension of support. You have case managers, you have case workers, but peer workers, third dimension of support, gives you that unique perspective that someone can actually, one, model the recovery. Housing away from homelessness is a recovery just like living with mental illness. So to have someone who models that can provide hope, real hope that, hey, I feel you, mate. I've been there. I'm sort of doing all right now.
I think that, and the other thing I would point out is having services, not having someone have to come to you for services. Like J2SI and a lot of our services are outreach, so we go to where people are, and it's not, okay, I'll see you on a Monday at 9 o'clock, and if they're not there, oh well, I'll try next Monday. It's nah, we're just going to keep trying until we connect. I mean, we've had people who've gotten to the level of like leaving letters at the chemist where they knew they were picking up their prescription, whatever it's going to take. And because you mentioned disengagement a bit, and look, it still happens with us no matter what we do. But we're always looking for ways to keep people engaged, because that's when the difference is made.
Can I perhaps introduce workforce capabilities? Cameron, you spoke of these people are incredible who offer these services and this care. And your words were effective care is very challenging and requires a high degree of very refined skills. Can you speak more to that topic?
I think, Spike, you probably say a bit more about this, probably a little bit better than I could. But
I don't think so.
Well, I was just going to say, I mean, I get a ton of chances to talk, right? So I feel like it's really good to
okay.
pass it around a bit. But look, my feeling is that we all know that this is really challenging work. It's not remunerated very well. It's not regarded very well. It doesn't have the kind of status that other kinds of roles in society have. That's a big part of the problem, right? That this is. I want to come back to your notion of place, because it feels like I always start my premise. My starting place with this work is, what kind of city do I want to live in? So you're talking about Melbourne, right? Like, what kind of city what kind of Melbourne do I want to live in?
Yeah.
And I want to live in a Melbourne where you feel like you've got as much of a place or as much as a right to it as I do, because that means that we all live better together, right?
Yeah.
And so, I mean, that's really hard work to do, right? I mean, how do you leaving notes at the chemist, right? Like, how do you think of that? You think of that because you really care about someone and you really care about the place that you live in. And my feeling is that we want to build communities that we all feel like we have an attachment to and that we feel that we belong in and we can thrive together, right?
Yeah.
And so, I mean, that feels like there's not a very good role description for that, right? If your role description is caseworker or whatever it might be, but the actual work is, how do we live well together? I'm not quite sure that we train people properly, and I'm not sure that our universities do a good enough job of preparing people for that work. I don't think we pay people enough. I don't think we've got the right, supervision, referral, debriefing in place, all of the stuff that we need for a system to work well. We've got a lot of that stuff in place, and a lot of it is just really, really hardworking, dedicated people who try and invent it every day. And I feel like great conferences like this are great because we get to learn from one another about how do we do that well. And I think that's a starting point, right? The other thing I want to say quickly is these panels remind me of how we actually know a lot of this already. And so the challenge is, how do we share the models, right? So what you guys are doing in Queensland, that's great. That's awesome, We should be doing that everywhere. What's happening with J2SI and with Greenlight, I mean, Housing First before that in the States. I feel like as a researcher, I probably shouldn't say this, but my feeling is we've actually got enough evidence already. Now it's about how do we hear more from you?
That's the other thing.
Yeah.
I mean, I just think that the evidence from J2SI is that when people are supported and that they've been provided with the accommodation that works. So what's stopping?
I don't need a job anymore, right? I don't need a job anymore.
It's frustrating though.
Yeah.
It's incredibly frustrating.
Well, it's also, and probably not the right place to say this, but it's also really expensive. I think that's a big part of it. And in our latest kind of J2SI, it's a social impact investment, which meant that we kind of put up some of the money. We have guarantors who are guaranteeing the money, and we have to make certain outcomes. Fortunately, yes, we've outperformed on each occasion to date. My fingers crossed, because who knows what will happen next time around. But yeah, it's a significant investment to think about working with someone for 3 years, because we don't, in these programs, we're not working with someone who, maybe lost their home 3 months ago, and it's really the pointy end. It's people who no longer go to access hubs because they're not going to get anything. They're going to say, oh yeah, I can put you in a rooming house. That doesn't work for people. And is that really living? You know what I mean? So it's really about finding ways to fund things, because at the end of the day, you're right, it's very well researched all around the world. It saves money, and sometimes that's the only argument I'll give people, because you have to know your audience, right? Some people only care about that. But it also changes lives. I mean, just a little bit of, we have someone we brought in that started with J2SI 2 years ago. During the time she's been with us, she's gone back to school. She's now a nurse. I mean, and this is someone who met the criteria to go into a program for people who've experienced long-term chronic homelessness and disadvantage. So that support really can change lives.
So I was just going to say that the last word is disadvantage. It's inequality. It's the way we distribute resources, and it's a political issue. And the people that hold the purse strings, I mean, it's about how, you said it earlier, like if we want to live in a society where everyone feels welcome and everyone has access to a roof if they want it, because there's people that we work with that for whatever reason, the four walls, it just doesn't work for them. They've turned accommodation down. Sometimes they change their mind occasionally, but that doesn't mean. And so the argument against it, that they still need access to healthcare and services that still need to be there, but giving people access to the support, because navigating the service system is really hard. It's really hard.
Can I jump in on that bit? Yeah, that's the peer bit, right? That's what we found in our report, this idea that I don't understand how this whole thing works. You're asking me to behave in a certain way. I need to go and talk to someone next Tuesday, and then you want me to, after that, wait for 2 weeks, then go and talk to someone else in another part of the city. I just don't understand how that works. So services that have that peer piece, that idea of you can help me understand how this quite strange system works and why I can't get help now and why I have to wait so much and why it takes so long. I think that part of trying to understand how the system works and how to navigate it and how to live with it.
It's punishing.
Yeah, exactly. Yeah.
For the people that were in the hotels during COVID, they were told they get a letter underneath their door. You have this accommodation for 2 weeks, and then we'll get in touch with you. So they've packed their bags. So we were doing outreach to these guys. So these people had their bags packed at the door. Then they might get a last minute call saying, "No, hang on, we've extended your stay." It's just, and so they wonder why people are using drugs. I'm using drugs because you're driving me up the wall. It's just like, could you imagine doing that to any other family? They just wouldn't wear it. But when people are homeless or they're vulnerable, it seems it passes as okay. And it's just, I guess that's what,
Some of our initial data with regards to disengagement alludes to that. People just being treated like second-rate citizens. Sorry, I'm not coming today. You're right tomorrow. No foresight, no forethought with regards to that person's actually got a life too. You be there, I'll come round when I can. Can I just quickly go back to Karen's expense word? I see it as an investment. We just don't have the measurement frameworks to turn it into saying it's an investment. We had 63% of those 1,477 households that, and I said, we've set the bar really high before we say safe and sustainable, because potentially they're easy words to say, but are they really? So we've set the bar really high. So we're probably under-promising and over-delivering on that, because we're probably in the other category. Some people are sustaining, friends and family, for instance.
Right.
But because we don't have the measurement frameworks, those longitudinal social measures, we can't say it's an investment, it's an expense. Until we say we got the Smith family housed, and they've been housed for X amount of time, and we've got data that says that they're putting less pressure, or they're not touching the hospital and health service. Johnny's not coming in contact with the criminal justice system as much. dad's out earning, mum's out learning, and we're seeing a reduced income from Centrelink.
Yep.
There's where we can say that's an investment. That's why integration needs to occur in the service delivery components of government too, so that when we do talk about integrative funding, we can also appreciate the integrative savings that we're gaining by working together and getting those great outcomes.
Yeah, and those are the things that we actually collect. We collect the housing status and hospital bed days. So those are our kind of paid outcome measures. And we also look at kind of the use of the justice system. So it can, look, I don't do that part of it, but it's an arduous process, I'm quite sure. But there is a way to do it, and it does show significant savings. And like I've just seen the hospital bed days, particularly for cohort, just go way down. I mean, once someone is housed, their need to access kind of crisis emergency services also just reduces, because they also, not just being housed, they have someone that they're working with intensively for 3 years, and it's 3 years regardless. It's not, yes, we can dial up, dial down support. Sometimes people don't need, some people might need 5 hours a week of support. Someone else might get to a point they need an hour or an hour every 2 weeks. Whatever is going to work, yes. And we've gotten some good results. Oh God, am I talking too much?
No.
We just, if we, I'm not, but you only need to look at AHURI data with regards to the number of households that actually have repeat support periods in any given year. That's repeat services, utilising the restricted, valuable resources such as support services or housing. That's households that are cycling the system again and again, and I'm not just meaning 2 or 3 support periods. Just look at the data, it'll blow you away with regards to, that's where it's an investment, because we can stop that recycling of people through the service system that every time it's just trauma invoking.
Just a gentle reminder to our audience, we ask that you lodge any questions for the Q&A session through the app. It's in line with COVID safe practices. We're unable to pass a microphone across the room. So just if you could to pop that question into the Q&A app would be greatly appreciated. And on that note, I just might draw the conversation, the questions towards our overarching theme of system linkages. We have a couple of questions here. Interested in examples of good connections between service systems, for example, mental health and housing, and launching from that, how do we get buy-in from services to work collaboratively?
I might pick out one example. I think, look, we're getting a little bit better in our major metropolitan hospitals at bringing housing into the way we think about delivering psychiatric care, for example. So I think there are good examples where that is working well. What those examples share in common is people who work hard at sustaining those relationships and then bump them up to the organisational level. So whether that's a formal MOU or things that you've described in your work where there is an organisational component that kind of guarantees continuity. Because the big thing I'm sure we all know from working in the sector is that if it's relationship dependent, then people move on and those relationships are lost, and that organisational continuity falls away. So I think it's how do you get to the point where there's organisational agreements that outlast individuals. I mean, it's not easy to do because the work is so relationship dependent, but I think you need to try and get those structural features in place.
Just quick, at cohealth, there's a lot of co-located services. Like this is pre-COVID, so we'd have people from Justice Connect visiting a couple of times a week. There's the outreach team that are upstairs. The housing outreach mental health team are upstairs, and so that makes for an allied health team as well. So that means someone could come to cohealth, get a food parcel. If they had an issue with their feet, it's a one-stop shop. In that sense, that's for the people that we see, it works. But I guess there's a sense of at times it's like a bit of a mash sort of situation. You're patching people up. But I think in terms of service provision, it's an effective model for people, especially rough sleepers and people that have just been housed that haven't established themselves. Yeah.
Well, and I really can't speak to like a mental health linkage, but I can. With GA2SI, we made a connection with cohealth with Andrew Morrissey, I believe his name is. Is that his name? Anyway, he works with people who struggle to access primary care. So he's a nurse, and he would meet with them first.
Is that Fitzroy? Yeah.
Yeah, so it actually ended up meaning that we had people who hadn't seen a doctor, didn't want to see a doctor, that ended up, building this relationship and finally getting things taken care of that have been going on for like 10 years with people. And it's really just by kind of knowing who your cohort is. And you're right, though, these relationships have to they can't be all about who you know. It has to be at an organizational level.
And that's one of our learnings. We lovingly call it staggered start. Different regions have different levels of maturity with regards to collaboration and even integration. Spike, you're right, co-location is an absolute silver bullet. Overlapping to a previous life as a project manager, agile, you're together, you can solve it there and then. Those small spontaneous conversations that can happen without having to have a meeting, dragging someone across the city, you're there, you can do it. But with regards to the staggered start, in talking across the broader service system, yes, it's very much skewed towards personal relationships at the moment. That's a big change piece. It's intergovernmental as well, with regards to you need to be part of this rather than would you like to be. So in some regions, we've got child safety, corrections, QH, QPS, banging the door down like, can you go away? They're there, they're really sold, they're seeing the benefits through the data that we collect and report. And in other regions, the appetite for that is less because it's still at the personal level. Until such time as we have a consistent approach across those service delivery arms of government and even across the broader NGO sector, then we can only say we're really operating at the personal level at stake. It's working well, but can work a whole lot better if we have consistent appetite across each of the regions.
Is that because of funding, like the way money's distributed to services? Is that there's not those long-standing relationships or building sort of connections?
Churn rate's one, we won't get into that. We talked about personal relationships. The churn rate of the sector, as we know, it is a moving feast. So when you lose those relationships, sometimes they're never reformed. Yes, funding agreements, I know in our jurisdiction, are starting to have built in that, not you must, but contractually, you must work with other people. You must work as a stronger collaboration. But not necessarily a contract that says you're all going to work together.
I'd like to return to a question that was asked very early on in the piece, and it's for all of our presenters, but specifically for Stephen and Cameron. Your presentations talk about human connections. What about the role of technology in making this easier? Beyond a database, could technology support better decisions?
Absolutely. And I think this is one of the things that COVID has taught us, isn't it? That all of us have suddenly come to rely on these sorts of things and perhaps realise that they're a little bit better than we perhaps thought they were. So I think a big part of this is that there are all sorts of technologies that can work. I think this is a sector that's very much grounded in face-to-face care, and it would be, it'd be really... I'm loath to criticise that too much, but I think there is the default is that I need to see people, I need to work people, I need to work with people in the office. So I think there's possibly a degree of reluctance about embracing some digital tools that might help. So I think part of it is, and I think the last 2 years have taught us that some of these things are incredibly effective. Look what we're doing now, right? There are people who are at home, watching this on a laptop, asking questions. I think this is another way of working together. So I think we are learning. But I think a big part is, that's another skill set to develop, right? So I think this is, in the context of difficult work, trying to then, thinking about the people that you work with, in your staff, another set of skills to master, right? A new set of things to learn how to use. It's challenging, right?
We've got several pieces of work with regards to digital inclusion. I'll come back to a statement I made. Creating the environment might mean that, or it might mean face-to-face. I think it should be one of a range of tools in including and engaging with people. We've got some community housing providers that have properties strewn over vast regions, that takes 2 or 3 hours to get to. So there are some providers that are actually saying, hey, you know, what about some digital inclusion projects? So we're really seeing that as a useful tool, but not the tool.
I was going to say the same. It definitely can complement what we do in person, and we've seen through COVID actually that some of our, even like Women's House at Sacred Heart has done like teams, groups with women because the women were feeling really isolated. But, you know, not everyone has access to the internet, access to a device, knows how to use that device. So, I mean, it's definitely a tool, and it's definitely saved us a bit during this pandemic, especially in Victoria when we were in lockdowns for so long. And I think that we should continue to develop it, but it should never be the go-to, I don't think, in my opinion. Sorry.
Where are the allies outside the sector? This delegate asks, how can we engender a collective community responsibility for changing judgmental narratives?
That's an awesome question.
Community orgs, I know in a lot of the regions, you know, we're closely linked with, or they're closely linked with groups such as Rotary, Lions. We're not scared as well to do community consultation and education with regards to those more citizen-led responses to homelessness. We're recently trialling in several regions a citizen-led response with regards to bed down, which is using car parks for a safe space for people to sleep. So there's lots of citizen-led. Orange Sky is another one that's probably national now. A lot of people might have heard of Orange Sky. Again, originally it's a lot larger now, but was citizen-led. So it really is about that place-based approach again, is knowing your community. It's the community from including, you know, it's everyone. It's that holistic approach. So concerns, and as I mentioned before about primary contact points, that might be a community, somebody in the park who's got a concern about seeing a tent come up, or a young person that seems to be just wandering around regularly over a period of time. So it is about tapping into what community thinks. It's certainly not an out of sight, out of mind thing. We, it's collective we, can resolve homelessness if we all work together.
We have another amazing question. System linkages seem to work well during times of crises, example, the current and previous natural disasters. Do you think there is a reason these linkages seem to break into silos again when the crisis has passed?
Can I? Sorry.
Yeah, grab it. Yeah, please.
COVID was a pandemic, I think. Should we not treat homelessness like a pandemic? Because behaviours change. Earlier in the conference, we talked about resilience, and motivations changed when we suddenly had to support people who were in shared living environments or living out in the out in open spaces. It was a public health response. Where's the homeless response that's the same? If we can do it then, we can surely, what's changed? We can't see COVID. You know, we hear of the tragic loss of life because of it, but we can't see it. So the conditions for us haven't really changed. It's just that people aren't saying it's as much of an issue now with regards to a public health response. So to me, homelessness is a pandemic that we need to resolve immediately.
And I guess that's what added to the cynicism, is that when people saw that this hotel accommodation could, you know, it happened within, you know, weeks, and it just adds to that sort of negative sort of view as that why didn't this happen why didn't it happen 10 years ago?
Yeah.
And it was hard to answer, because the answer is because there's a sort of perception. There's a way of seeing that we don't want to, that Tony Abbott thing, we don't want to reward people for bad behaviour, what some people view as bad behaviour. And I think could that? I mean, that's what I feel. I think there's a political aspect to this. You know. Yeah, I really feel it's just the whole discussion about the dole being like $500 a fortnight, unemployment benefits. It's not just housing; it's support, access to healthcare. It's well, you know, benefits. You know, like climate change. Even, we're still arguing about same. The whole thing. The community seems to be ahead of Parliament on so many things, and this is another one where they're just.
The glorious People's Republic of Fitzroy is anyway.
Yeah, well, it's they're the ones that control. You know, if 6,000 houses need to be built over 10 years, who's got access to the funds?
I think part of it is I completely agree with everything that's been said. I think part of it is linking some of the narratives together. So there is a sense that, because I think sometimes the problem is that we end up, those of us who are interested in social justice issues end up competing around attention. You know, I'm thinking about, we've got a Royal Commission into mental health, and so the sense is there's a lot of discussion about mental health. You know, a couple of years prior to that here in Victoria, there was a Royal Commission into family violence. So there's lots of discussion around family violence as if those two things don't fit together. And so I think sometimes we get caught up in what we're, I think, talking about is what kind of place do we want to live in, what kind of community do we want to live in, and how do we connect some of those things so we start talking about, can we work together so that we're not competing over, homelessness is the most important thing, we need to be talking about that, or is it family violence, or is it addiction, what is the issue? The issue is that, we live in a society that's becoming more unequal, and that's causing all sorts of problems. And, my PhD is in political science, and so, the answer I always feel is get fucking organised, get organised. Get involved in politics, get organised, yell about it, I think it's hearing you talk about it, it's like, you need to hear the stories, right? And so, because I think it's really easy not to bash the Herald Sun, but that's easy to do as well. But, it's really easy, if you leave that space for people to say, this is what homelessness is, then that's the narrative that's going to take hold. If you listen to people who have lived it and have something to say about it, then a different kind of narrative takes hold. And that's politics, right? That's, have a voice, use it, get active, get organised.
And be allies, because aren't we all suffering from the bigger narrative that is full of myths about the human condition, right? That individualness and personal, we have all this personal agency, that there aren't structural reasons why people, all those questions, that dependency is a dirty word. Only independent people are successful, which is rubbish for any human that needs to be connected to other people, and we're interconnected and we're interdependent. Do you know what I mean? So it should, to me, it's also, sometimes we ask a lot of people who've had lived experience of any really traumatic situation to be the ones to make the point.
Yeah, that's so true.
We need to all, not that I don't,
exactly.
We need to be allies in that, to say we're telling lies about the human condition, and we're getting the society that you get as a result from that, and we're actually incentivising. So, people go carve off their particular structurally vulnerable population because they can get money for domestic violence, or they can get money this month, we can get money for this. You know what I mean? So the whole thing works to reinforce that. And I'm probably still Pollyanna-ish. I thought I was getting too old to become cynical, but clearly I'm not. That I just wish that we could take a more of a, not see this as an individual issue, but a collective responsibility for what kind of country we want Australia to be.
That's politics, right? I really think that's the politics bit. That's we get to decide, aren't we lucky? We get to decide as a community what kind of city do you want to live in, and that's and so. But we've got to take some responsibility for that as well. We've got to be like I've heard a lot across the course of the conference, right? We've got to start getting more organised, and getting a bit more organised online, getting a bit more organised face to face. Speaking a bit more loudly, I think, and that's. It's an election year, right? We'll keep hearing it, so yeah.
And on that wonderful note, I would like to ask you to join me once again to thank wholeheartedly our panel of presenters. We have Stephen, Cameron, Spike and Karen. I also wanted to thank Homes Victoria, a conference partner, and for all of you in person and online. And before leaving, if you have the energy and the time, we do offer you a short survey on the session, and we ask that you please complete it. Thank you so much.